Good evening, everyone. Thank you so much for giving up your time to listen to the talk this evening. We're going to talk about a holistic approach to lipid management, and this is all about applying therapies to our patients with consideration to age, risk, and comorbidities. We know there is this linear relationship between LDL and the development of atherosclerosis and vascular disease, which is now driving the increase in cardiovascular deaths. Up to a quarter of deaths in England now are due to CVD. But it's not, of course, all about deaths either. Nearly 7 million people now are living with the impact of having a vascular event, including the impact of having heart failure and the impact of having strokes on disability and the inevitable impact on employment. Cardiovascular disease is also the largest cause of premature death in deprived areas. And whilst we know that familial hypercholesterolemia causes premature coronary heart disease, we also know that this is significantly underdiagnosed, and yet CVD is potentially preventable. And we also know that CVD risk factors are also risk factors for many cancers and for Alzheimer's disease. And it's the largest area where the NHS can actually save lives in the next 10 years. And so this is driving national and regional strategies for CVD prevention. And you can see the national ambitions there on the right, which include improving CVD risk assessment and treatment and improving the diagnosis of FH. However, we could suggest that this doesn't go far enough in terms of what the guidance suggests and how we can actually improve outcomes in lipid disorders. This is a Department of Health chart published in 2018, which details the net costs and savings accrued over 20 years with a range of CVD prevention interventions. And it's interesting to note that actually statins in the first 5 years of use produce the most cost-effective benefit. If you then add in antihypertensives, that benefit continues over a 20-year period. I hope you've listened to some of the lipid management webinars so far. This summarises the topics that we've already covered in our 4 webinars, and this is the 5th and final tonight. If you haven't, then these are still available to watch. So far, we've covered a primary and secondary care perspective, the use of statins in detail, are they a good thing or not? Indeed they are. And also covering novel therapies and driving down LDL-C as low as possible, as early as possible, and for as long as possible, and how we can pick up familial hyperlipidemia. But tonight we're going to try and bring all of that together and take a holistic approach to CVD prevention. There's not much point just addressing cholesterol or any one of these risk factors on their own. To maximise CVD prevention, we need to consider and optimise all of the risk factors for maximum benefit. Because some things are not modifiable: ethnicity, family history, and age. And in terms of clinical impact that we can have on deprivation, we can certainly signpost people to help. Lifestyle includes that cycle of behaviour change to push people to make those decisions and changes. But of course, that is a personal thing that people need to want to do. But again, we can signpost and encourage. But all those red conditions there, we do have medications that we can use to improve the outcome for our patients. And cholesterol is a huge part of this. So the key aims for a holistic approach to lipids, we need to be thinking about the use of lipid therapies as just one part of CVD prevention, often overlooked in our chronic disease management consultations. We need to make every contact count to identify and treat familial hypercholesterolemia. NICE actually tells us that we should be diagnosing this as young as possible, by the age of 10, if at all possible, in order to reduce that premature vascular disease burden. We need to make every contact count to identify people who are at high risk and would benefit from either primary or secondary prevention therapies. And as we start to diagnose more familial hypercholesterolemia, we will have younger patients on lipid therapies who can then become pregnant, of course, or want to plan a pregnancy. We need to be able to counsel patients about their risk of having a child with familial hypercholesterolemia and how to manage their lipid therapies before, during, and after their pregnancy. At the other end of the spectrum, when do we stop prescribing lipid therapies? When is it appropriate to still continue in people with frailty and multimorbidity? And of course, tailoring lifestyle interventions right across the age range and comorbidities is vital. And so tonight I'm going to illustrate the talk using a lifespan approach to lipid management. This will start by focusing on children and adolescents, and the main aim here is to try and pick up FH as early as possible. Likewise in the young adult years, and then moving on to the 40 to 74-year-old population, which you'll probably all be more comfortable with, where we use the NHS health checks to facilitate CVD risk assessment. But what about people who are 75 and over, for whom there's nothing commissioned to check their CVD risk? These are the fit and healthy 75 years and over, who inevitably do have high CVD risk, but may not be coming to see us regularly. And then, of course, deprescribing and making those decisions to stop lipid therapies as people move towards end of life. Cutting across all of that and the whole age range are chronic disease reviews. These are patients that are already seeing us, who are probably at high risk of CVD. And how do we ensure they have effective treatments? And as I said, applying lifestyle modification with consideration of age and ability right across those age ranges. Before we launch into that generational approach, I just wanted to give you a few tips about the lipid profile, as of course the diagnosis and treatment will hinge on our interpretation of this. And for the vast majority of patients, we will be using a random lipid profile which provides a non-HDL-C that we will use for almost all diagnosis and treatment decisions. And this is a very accurate variable to use and a very stable path lab test to do compared to perhaps an LDL-C. A fasting LDL-C is actually only required if triglyceride levels are very high, so definitely over 9, but also when we're considering a possible diagnosis of familial hypercholesterolemia. NICE also tells us that we should be checking a fasting LDL-C to check eligibility for injectable therapies. However, we do know that a non-HDL-C of less than 2.5 is approximately equivalent to an LDL-C of less than 1.8. And there are actually now some laboratory equations that can be embedded into the path lab to allow them to report an estimated LDL-C from a random lipid profile. And we may see this coming through over the next 12 months or so. We can also use an online calculator to provide an estimated LDL-C using a random lipid profile. And I've embedded a link there, and these slides will, of course, be available for you to view and use that. In terms of the total cholesterol and total cholesterol HDL ratio, in general, these are now really quite unhelpful for the diagnosis and for treatment decisions, except perhaps in one instance when using a total cholesterol as one variable in considering the biological diagnosis of familial hypercholesterolemia. So to the first part of the generational approach to lipid management, childhood and adolescence will be something we're not particularly familiar with when considering lipid disorders. And the main aim here is to make that early diagnosis of familial hypercholesterolemia, because this is a real opportunity to reduce the burden of premature vascular disease. And as I said earlier, NICE have been recommended that we diagnose familial hypercholesterolemia, if possible, by the age of 10. Or as soon as possible, so that we can start treatment early. How can we do this? At present, the only real mechanism is by cascade testing following identification of somebody else in the family. We do also have the new child parent screening NHS commissioned service, which is in pilot phase, due to report next year in terms of effectiveness, and I'll talk about that a little bit more in a sec. But maybe we should consider other approaches too. For those of us who've lucky enough to have point of care testing in a practice, potentially in a practice or in another community or in secondary care settings, of course, maybe we can do a point of care test in children as a single screen to look for FH. We can also do an opportunistic lipid profile, particularly in children where we're doing blood tests anyway, where children are attending secondary care for blood tests. It's an opportunity to check that. I'm just going to go through the process of child parent screening, which is a really exciting pilot that looks at screening a baby round about the age of 12 months with the aim to cascade test the whole family, and when the child is positive, to start treatment at least by the age of 10 at the latest. So for children to be eligible, they have to be between 11 and 24 months, and usually the test is performed during routine immunisation. The parents are invited for immunisation, and this includes information about FH with an offer of an FH screen using a heel prick point of care test. The parent then brings the child to the practice nurse or whoever does the immunisations, receives some healthy lifestyle information applicable to the whole family. Consent is taken for the point of care test, and a heel prick blood test is taken. It then takes 7 minutes to get a total cholesterol measured using a point of care test. And then what you do next hinges on what that total cholesterol is. If it's less than 5.3, then no further test is recommended. If, however, that total cholesterol is equal to or greater than 5.3, we know that 5 out of 100 of those children will have FH. So a second sample is sent to the genomics lab. If that sample then proves to diagnose a genetic FH mutation, it's recommended that we do check a full lipid profile at some point. If the LDL-C is less than 5, then the recommendation is to recall by 10 years and start treatment at that stage. If it's equal to or greater than 5, these children are much higher risk, and we should perhaps consider whether treatment should be started earlier. We need to take into account if the child has a family history of premature cardiovascular disease, and this would be an indication to involve specialist services much earlier. And at that stage, we also undertake cascade testing for the whole family. If, however, no FH genetic mutation is detected at this stage, this is a slightly grey area, because we know that despite the advances in genetic testing, we possibly are not diagnosing all FH at the moment. So it may be, as technology advances in coming years, that we will be able to pick more up. So the recommendation is to recall this child to consider further review by the age of 8 to 10. And of course, for all of these, lifestyle modification information and advice is vital. And that children of this age, it's a real emotive time when a parent is developing healthy lifestyle and habits for their children, and it's a great time to introduce this information. Just one red flag: all children with suspected homozygous or proven homozygous FH should be referred straight away to a specialist, usually heralded by an LDL-C of over 11. These children are going to develop very early coronary heart disease and will require specialist treatment. I'm going to move on now to the next step in our generational approach to managing lipid disorders, moving on to the 18 to 39-year-old bracket. The aim here remains the same, really, as for children, in that we are looking to pick up familial hypercholesterolemia as early as possible and to treat effectively. Again, at the moment, there is no commissioned way to pick familial hypercholesterolemia up in this age group. We are relying on cascade testing following the opportunistic identification of another family member in the first instance. So should we be thinking about an opportunistic lipid profile for these people? We will only need to do one, of course, during this age range to make a decision as to whether their FH could be a possibility. We could do this via a point of care test. It needn't be in a general practice. It could be in any community or hospital setting. We have, of course, over the last year or so had the PCN DES encouraging us to use digital tools and IT searches to try and look up patients who appear to have FH. Of course, that's only as good as the lipid profiles that sit within the patient records. And if patients are not having blood tests, then of course we will be unaware of their diagnosis. So I think this is all about considering a single lipid profile in this age group in order to determine whether there could be a risk of FH, unless of course they do have a significant other vascular disease, in which case they will probably come into your chronic disease management clinics instead. This slide illustrates the diagnostic process of FH quite simply, really. So this is a combination of the biochemical diagnosis on the left combined with the history of premature coronary heart disease, particularly personal history, but also family history. A personal history under the age of 40 is very significant, and we really should be considering, does this patient have familial hypercholesterolemia? And also the physical findings, xanthometer and xanthelasma, corneal arcus, are suggestive of familial hypercholesterolemia, but their absence does not, of course, exclude it. Though for patients who do have xanthometer, which probably accounts for about 30% of patients with FH, they do have a worse prognosis, so it is important to look for these and ensure that we are optimizing treatment for them. So we're combining the biochemical elements with the history of premature vascular disease and physical findings. We then need to use a genetic diagnosis calculator to consider whether genetic testing should be undertaken to make a definitive diagnosis. And we have the Simon Broom and Dutch Lipid Network criteria, which I'm sure you'll be aware of. In Cheshire and Mersey, we have picked up the Welsh Lipids score. The benefit of this is that you can do a genetic risk assessment on a patient who is already on lipid therapies, which I think is quite helpful, particularly if you're dealing with somebody who's already got coronary heart disease. And at that point, you do need to refer for genetic testing to the service that's local to you. For people who do have severe hypercholesterolemia, it's always worth considering whether there could be a secondary cause, of course, particularly in people with type 2 diabetes, hypothyroidism, significant renal impairment, or cholestatic liver disease. There are other rarer things that can push up your lipid profile, like Cushing's syndrome, and of course there's a variety of medications that can also do that. This slide just summarises the key points for treatment for familial hypercholesterolemia. We will still treat patients the same as we do for primary and secondary prevention. The subtle difference is that the targets are tighter. So for primary prevention, we want to drive down their LDL-C or non-HDL-C by 50% from baseline. And we must remember, particularly if we work in primary care, that PCSK9 inhibitors are available as a secondary care treatment to help drive down their cholesterol if they're not to target. I said earlier, if patients are homozygous, that they should be under a specialist, of course. As we start to have younger people, as I said earlier, on lipid therapies or with a diagnosis of FH, we do need to be able to provide counselling, or at least have an awareness of the risks of using lipid therapies in these patients. And of course, people will be wanting to know what their risk is of having a child with familial hypercholesterolemia. And that's particularly relevant if both parents, of course, have familial hypercholesterolemia, when I think specialist advice is absolutely vital. We need to understand how to manage lipid therapies before, during and after pregnancy. In general, the advice is to stop statin medication 3 months before pregnancy and not to restart until breastfeeding is complete. However, it may be that for some people with high-risk FH, that medication is continued, and of course, specialist advice is important to support that, as there is a potential risk of preterm birth and low birth weights, and a theoretical risk of fetal malformations. Perhaps moving on to more comfortable territory in the 40 to 74-year-olds in the form of NHS health checks. This is something I'm sure most people in primary care will be all too familiar with. This is, of course, the fit and healthy population. These are commissioned every 5 years, no more frequently, and people who are eligible only if they are fit and well, so they don't have any of the conditions detailed there. So they don't have FH, and they've not previously been found to have a CVD risk over 20%. The process will be familiar. Patients have a blood test prior to appointment, and then a face-to-face assessment where variables are recorded and a CVD risk assessment is undertaken. NICE now recommend Q-risk 3, of course, to measure CVD risk and to consider lipid therapies if CVD risk is 10% or more. You may, of course, wish to treat new findings first that have particular impact onto the lipid profile. So new uncontrolled type 2 diabetes, hypothyroidism, liver and renal disease, or very significant potential to reduce, to improve lifestyle. Moving on to chronic disease reviews. So this is all about trying to make every contact count to identify people who are at high risk of CVD to treat for primary or secondary prevention. So the patients that we all will be seeing include those listed for secondary prevention there. So all patients with coronary heart disease, angina, MI, any kind of revascularization, stroke, TIA, peripheral arterial disease and aortic aneurysm. We should be treating these people without delay immediately after a vascular event. So they should be discharged on at least a starter for 10 lipid therapy, which is usually high dose, high intensity statin. But we need to drive down their cholesterol to target. So when we review these patients at chronic disease appointments, we need to ensure we are optimizing their therapies. For other people that we don't need to use CVD risk assessment for, include patients with type 1 diabetes with one other risk factor. So patients who are over 40 or have had type 1 diabetes over 10 years, or who have nephropathy, or people with CKD 3 to 5 and or albuminuria, or as I said earlier, familial hypercholesterolemia. We shouldn't be using Q-risk, and again, we should be treating without delay. But for these people, it's for primary prevention. And again, for primary prevention, but in this instance, we should be using Q-risk 3 and treating if their risk is equal to or over 10%. The patients that will appear in our chronic disease review clinics are probably all high risk, and that includes those in the list detailed there, including type 2 diabetes, hypertension, any kind of systemic inflammatory disease, severe enduring mental health problems and learning disabilities, and smoking-related disorders. People aged 75 and over who are fit and well, we really do need to make every contact count to ensure that we are considering CVD risk assessment for these people, because there is no commission service to do this otherwise. For most people, they probably will have had a CVD risk assessment at some point, but if they've never had a CVD risk, or their CVD risk has previously been less than 10%, by the time you get to 75, it is likely that you will be high risk due to age alone. So it's worth periodically considering CVD risk assessment if somebody's not on lipid therapies at this age. And if they haven't been checked, considering undiagnosed other chronic disease, such as hypertension and diabetes. If a patient of 75 and over has previously had a CVD risk of over 10%, Of course, this only goes up with age, so we don't need to repeat this, but we do need to consider the reasons for not using treatment previously. Perhaps they were statin intolerant, or perhaps therapy was declined. Likewise, for people over the age of 85, these people are already high risk, and you do not need to use a CVD risk assessment. But of course, we do need to offer lipid therapies in the context of tailoring it to the person, of their biological age, of their frailty, their life expectancy, and of course, patient choice. So when we do move towards frailty and life-limiting conditions, how do we make a decision on whether we should use lipid therapies or not, or when should we not prescribe anymore? Unfortunately, there's no easy algorithm. We need to tailor this to the individual. The times that we should be thinking about, do we prescribe or do we deprescribe, are of course life-limiting conditions. People with metastatic cancers on the GSF, progressive organ failure, significant dementia, people with severe frailty, with escalating hospital admissions and increasing social care needs, people with complex multimorbidity. But that said, that has to be balanced against their risk of having a vascular event. If somebody is currently coping well and wants to avoid a vascular event, it may be entirely appropriate to continue lipid therapies. So it is a balance in terms of making that decision, and that's a discussion with the patient. Just want to touch on lifestyle modification, as this is important right the way through the pathway. We need to consider age and ability when we think about healthy lifestyle. And of course, this is all about smoking, exercise, diet, and alcohol. I used to think cigarette smoking was just prothrombotic, but actually it does significantly increase LDL cholesterol and serum triglycerides. Smoking also reduces good fats, it reduces liver excretion of LDL-C, and so directly accelerates atherosclerosis, causing cardiovascular disease. I think this is just another important piece of information to tell patients to help reduce their cholesterol and to help move towards that behaviour change to stop smoking. This table just summarises national guidance on exercise right across the age range and ability. And of course, at any stage, it's possible to increase and escalate exercise. Any increase in volume of activity is good, and any reduction in sedentary time is important. I think this provides a guide for our patients on what their exercise should be and how to advise them. When we talk about diet, we're talking about a healthy diet, but also about achieving a normal weight. And for cholesterol, about foods that potentially can reduce cholesterol. And in summary, that's all about reducing the amount of fat in terms of the percentage of energy consumed, reducing saturated fats, increasing whole grain carbohydrates, increasing fibre, having lean and plant-based protein, increasing fruit and veg and fish, and having that focus on a Mediterranean balanced diet. When we're trying to achieve a normal weight, it may be that we need to support with specialist services or even bariatric services for people with a very high body mass index. But for most, it's about taking a tailored approach to a healthy diet, ensuring people understand how to control triggers and are able to self-monitor. So a lipid talk would not be a lipid talk without understanding the sequencing of lipid therapies for primary and secondary prevention, and how do all these drugs fit together in the jigsaw of treating patients with lipid disorders. Over the next 2 slides, I'm just going to give a very simple overview of a way to think about primary and secondary prevention. So primary prevention for people with raised CVD risk. So these are people that will have a CVD risk over 10%. We want to think about starting a high-intensity statin in the first instance, of course. So this is usually atorvastatin 20 milligrams, and we're aiming for a target non-HDL-C reduction of less than 2.5. We would usually review a patient with a lipid profile around 3 months to check their target is achieved, check compliance and side effects, and then optimize the statin dose as far as possible. If there are statin side effects, I would encourage you to use the statin intolerance pathway, which we've talked about in previous webinars. If their target's not achieved on their maximum dose high-intensity statin, at that point, we can then add in ezetimibe monotherapy, review again at 3 months to check the target is achieved. If no statin is tolerated, at this point, we can consider ezetimibe monotherapy, review at 3 months, and if they're not to target, switch to the bempedoic acid and ezetimibe combination therapy, and again, review at 3 months to check the target. If people are to target, but on either maximum dose high-intensity statin plus ezetimibe or ezetimibe and bempedoic acid combination, we will usually be reviewing these people annually with a lipid profile at the least. I would suggest we consider referral for advice if we're not able to treat to target, but particularly if there's a suspicion of familial hypercholesterolemia having not been diagnosed, as of course they will have then the option of using PCSK9 inhibitors. Very simple approach now to secondary prevention treatment algorithm for people with cardiovascular disease already. So again, we're starting with a high-intensity statin. That atorvastatin, usually we would come in with 80 milligrams. This might start at 20 for people with CKD3, or if there are other problems. But once again, we're still aiming for the same target of a non-HDL-C less than 2.5. And we would again review at 3 months to check the target as before. And if target's not achieved on a maximum dose high-intensity statin, we have some choices for people for secondary prevention who have cardiovascular disease. So these choices are either to use ezetimibe or inclisiran in the first instance. A way to clinically rationalise that might be if we've only got a less than 20% non-HDL reduction needed, we could consider adding ezetimibe first in the first instance, as we know that's likely to drive them down to target. We would still review the lipid profile at 3 months, and if they're not to target at that stage, we can consider the initiation of inclisiran. Conversely, if we're more than 20% away from target, I would suggest we consider using an inclisiran first, as that is more likely to drive them down in the first instance. Again, review the lipid profile at 3 months, and if target's not achieved, we do still then have the option of adding in ezetimibe. For people who were not able to tolerate any statin at all, despite going through the NHS statin intolerance pathway, again, we've got some options. We can start ezetimibe monotherapy, much as we did for primary prevention, and if not to target, at 3 months, replace with the bempedoic acid and ezetimibe combination. And again, at that stage, we can consider initiating inclisiran if not to target. Or if no statin is tolerated, we can, in theory, go straight to inclisiran if they are eligible. We can review at 3 months, and then, if not to target, consider ezetimibe as above. If target was achieved on a high-intensity statin, or we've gone through all of these therapies, at this point, we should consider the addition of icosapent ethyl if a patient is on a statin to reduce their cardiovascular risk. That's only done, though, for patients who have a fasting triglycerides of equal to or greater than 1.7. So this icosapent ethyl is to reduce CVD risk in people who are on a statin who continue to have raised triglycerides, but they must have LDL-C levels between 1.04 and less than 2.6. There is no target for icosapent ethyl, it simply reduces CVD risk. For all of these patients, if they are to target, we'll be reviewing them annually as we were for primary prevention with a lipid profile. We should consider referral to a specialist if we're not able to achieve target, and indeed, once again, if the patient possibly has undiagnosed familial hypercholesterolemia. I guess you may ask, why are we referring at this stage for possible hypercholesterolemia if a patient is at target? Well, of course, if they do have FH, they will have family members with FH, and this is an opportunity to pick it up. So I just want to summarise some of the points on taking a holistic approach to lipid management. We need to understand that lipids are a key part of maximising CVD prevention, and if we don't address lipids, we are missing a crucial step in improving outcomes. We do need to make every contact count to move people to behaviour change to modify lifestyle risk factors. And I think I've said lots of times, we need to think of FH early, as the opportunity to reduce premature cardiovascular disease is often missed. Understanding CVD risk is vital, knowing who in your population you need to do this for. Taking this multi-drug approach to lipid reduction for both primary and secondary prevention, and treating to target. Optimising lipid treatments, to reduce cholesterol as low as possible, as early as possible, and for as long as possible. But most of all, of course, when thinking holistically, tailoring treatment decisions to the patient. Thank you.